Thank you for that great description. I don't think anyone's ever called me a woman's best dream. Maybe I'm embellishing what was nightmare, more like it. I can always tell what kind of patient, who my patient is at Costco, because if I deliver their baby, they run towards me. And if I've seen them for anything else, they run away from me. So, just basically, I'm here to talk a little bit about what I do and impart some wisdom in my 2 years of practice to you about talking to patients about difficult issues. My practice focuses on sex. It focuses on unprotected intercourse and basically the consequences thereof. So I deal with sexually transmitted infections, cervical dysplasia, unintended pregnancy. I deal with patients who greatly want to increase their risk of acquiring those conditions and can't, and I walk them through those various steps. And basically, every single day, I ask people about some of the most personal aspects of their life. So, to take you back to how I got into this business, we have to go back to 2000. So, that was a long time ago, and at that time, necklines were plunging at an alarming rate, and there was a worldwide shortage on frosted tip dye. We really thought this was attractive back then. I apologize. And I had hair, not much of it, but I had some up at the top there, so you can see that. And I was at a crossroads trying to figure out what I was going to do with my career. Like probably many of you, in high school I did well in biology, and I thought, well, maybe medicine or something like that, because who really knows what medicine is when you're 16, 17. And by the time I got to undergrad at Guelph, I realized that I didn't think medicine was really going to be for me, and I was going to pursue a career as a social worker. And I was really into the social justice movement at that time. It really resonated with me, and I thought, you know what, this degree in biology, minor in women's studies, and I'll go and do my MSW, and everything will be great from there. And then something happened. I got sick. And for many of us, our first experiences with medicine are largely around primary care. And in fact, today, some of you in the room will have never actually experienced being a patient in any other capacity other than patient care. And what I will always remember about that time was how vulnerable I felt when I was the patient sitting in a bed, not knowing what was going on, one of those kind of random illnesses where it takes a long time to figure out what's happening. And you know, this is the time where I'm really putting my faith in, whatever that means, in a clinician's hands, because I don't know what's going on. And this is usually the part of the story where the clinician does a really great job and holds your hand and solves the mystery and you get better, and then I commit to always go and be just like those doctors and make a difference. That's how a lot of us went into medicine. But that's not what happened for me. What I experienced was judgment. I experienced assumptions based on how I dressed, on the person that I was dating at the time, on the piercings I had in my face, and basically on my general demeanor, because I was just one of those students with one of those random viral illnesses. And as a result of that, my care was delayed because they didn't figure out what was going on. Unnecessary tests were ordered, and some of those were even done without my consent. So where many people like to go into medicine because they were really inspired by somebody, I sort of took that approach of, if I get in, that's one less person like that doctor who can get into medical school. So spite can also be a great motivator in terms of becoming a physician. That's tip number one. Second thing happened to me around that time, shortly after I had convalesced from my time in hospital, and that was I started pursuing studies in women's studies. And then it became gender studies, and then it actually got canceled altogether at the University of Guelph because we've apparently already have equality, so we don't need to learn about that stuff anymore. But that's another story for another day. And basically, one of the things that really struck me was how certain institutions can maintain certain levels of oppression. And I didn't really have a good understanding about healthcare inequities. And what I experienced with the healthcare inequity, because I was being judged based on characteristics that had nothing to do with my medical history. And I really didn't know a lot about women's health at the time. In our social justice movement in Guelph, there's no abortion clinic in Guelph, so choice wasn't actually on our radar, because the women in our community were actually going to another town. So it was kind of funny. And we were fighting other good fights, vegetarianism, LGBT rights, they're important. But it's funny how when it's just not on the radar, it's not on the radar. And that's when I decided actually not only to go to school for medicine, but to pursue a career in women's health, and I've stuck it out from there. So I want to bring up a paradigm called reproductive justice that I think resonates with a lot of us. And the idea of reproductive justice is to move away just from the idea about reproductive rights or abortion care or contraception. What reproductive justice involves is recognizing that women and girls have both emotional and physical needs, as well as to some extent spiritual needs, that we can serve in terms of meeting. So to give you an example, when I see a patient in the abortion clinic, that person is coming to me as a result of all of the other factors that surround her in her life. So she might be there seeking termination because she can't afford food, and that could be intersecting with the fact that she belongs to a racialized population, and the fact that she's a woman, so she only makes 70 cents on the dollar for something that a man would do. And that may also intersect with the fact that she may experience violence in her home, or she may have a supportive partner who also is there to help her. And so we can achieve reproductive justice when we actually consider patients as their whole and as an integral part of their community. And that it goes far beyond any one specific task within medicine. So you can do reproductive justice if you're a gynae oncologist. You can do reproductive justice by doing cervix cancer screening in a population that's under or never screened. You can do reproductive justice by listening to your patient, by delivering their baby, by providing obstetrical care. You can do reproductive justice basically in any other aspect of women's health that you do. The important thing is that you consider that, you take the time. And one of the things I constantly am hearing from my clinician friends is, I don't have enough time to do this. Well, that's a construct that we create for ourselves. We decide that we don't have time to do that because we privilege certain aspects of care over somebody else's. Whereas in fact, when I think back to myself, and when I was a patient, all I wanted was for somebody to listen to me and to be respectful to me and to help give me care. I didn't actually care what the outcome was. And that would have been much more important. And maybe I still would be here, being a great clinician because I had a good role model. But that's all I wanted at the time. Because anybody can write a prescription for antibiotics. That actually only takes 2 seconds. So I did promise I was going to talk a little bit about sex. And so I do want to kind of get back to that because that is a lot of what I talk to you about with patients. And sex is obviously one of the taboos. And I actually talk to people about all sorts of things, ask them about all the things you're not supposed to ask about on a first date. So usually on a first date with a patient, I'm asking, their religious affiliation and their sexual history and their STD history. And, sometimes you talk about politics too. So you're pleased to break all the rules right from the beginning. So how do you do that? Well, I think the first thing to recognize is that if we don't ask, the patients aren't going to tell us. Now, I'm not here to say that we have to ask everybody. I'm not here advocating for putting it on standardized forms, because that is where we do get into a little bit of a problem with time management. If every single person who believed in a cause put their question on the animal health exam, it would take us 5 hours to go through our histories and physicals. But you do have to ask and you have to think about it. So just because your patient's in a wheelchair doesn't mean you shouldn't be asking about sexual questions. Because I can tell you I see a lot of patients with sexual dysfunction and good functioning who are disabled. You do have to ask the 88-year-old woman who's getting a pessary put in whether she has insertive intercourse. She will tell you all about her sex life if you ask her. And most of them aren't having insertive intercourse, but some are, and it's important to remember to ask about that. Similarly, you don't have to ask at certain times where it's clearly not going to make a big difference. So, the postmenopausal bleed in the moment that's being managed with an endometrial biopsy, it can wait. I'm not saying you have to do it all the time, but keeping the door open to asking these questions at least lets the patients know that you are an appropriate person to approach that. I think what's also important to know is that your patients do think it's appropriate for you to ask about this. We did a study back when I was a medical student, and one of the things that we found was that, first of all, patients are totally comfortable with being asked about sexual questions, and that we are the ones who have the problem about asking in the first place. And where patients get uncomfortable is when they sense that you are uncomfortable about asking it, because now they don't know what the answer is supposed to be. And so really the key there is the more you ask, the easier it gets. I ask people about masturbating about 50 times a week, probably. Not if they masturbate 50 times a week, but rather ask 50 women a week if they masturbate. And there's ways to do that. You don't have to come up with that way. You can come up with strategies. And really, you can get there. And I do say to people, a good example is practice amongst each other. Kind of, how would I ask these kinds of questions? Obviously, You can either be the standardized patient, or you can answer truthfully if you want to know all that information about your friends. But the more you ask, the more you can get some objective feedback about kind of what it is that you do. We all have funny idiosyncrasies, you just have to kind of know what they are and live with them. The other issue is trying to figure out what it is about us that makes us afraid of asking. And what you have to do if you're going to get comfortable with asking about these things is actually to take some time to think about your own upbringing and what the messages were that you got in your upbringing, and also what the messages you've got from your mentors and the clinicians that have taught you up until this point. Because there's always usually one talk about kind of asking about sex, and it's usually very tasky, and that's good. I think one of the problems with sexual education and sexual history taking is we've forgotten that sex is usually in the context of some sort of relationship, whether that's a verbal contract between two people that are meeting for the first time, or whether that's an established relationship or a marriage that's been going on for a long time. So usually, if you ask people who have good sex, what good sex involves, it's in the context of being free to share something with somebody else. It's not actually about the sensation. So we get bogged down in that, but that messaging we use about function and task makes us really anxious ourselves. The other big issue that comes up is the question about barriers. And what I can tell you about the evidence around barriers around asking about sex is you are much less likely to get sued or to get a college complaint if you do this as a part of your regular practice than if you're selective about it. So if you only ask certain questions to certain people based on certain presuppositions or traits, you're providing inconsistent care, that will absolutely increase your risk of a college complaint. But separate to that is, you have to ask yourself what it is that you are asking about. And let's say you're not asking somebody because you find them attractive. Well, you're also neglecting the fact that you are violating barriers in that person for attractiveness reasons, which is in and of itself problematic. So to explain that another way, if you look at why doctors actually sleep with patients, this is usually what happens. And I remind myself this sometimes when I'm having a really good day at work and I need to kind of shoot myself down. Romanians we're not a proud people, so the pride is like the worst thing you can have. But a clinician patients coming to see me in my sex therapy practice because they're here to see a doctor. They're not actually here to see me specifically. They may have asked for me, but they're only asking for me as a physician. They know nothing about my personal life, hopefully, unless they've Googled me and tried to find that information out. But they are actually asking an anonymous clinician who's just kind of a shell of somebody what's going on. What happens for the physician who violates boundaries is they start personalizing that. So they start saying, this person's coming to see me personally. They're coming to see Dustin. They're not coming to see Dr. Costescu. And as a result of that, I'm here to help Debbie, who's dealing with this issue. And we start violating boundaries because now we're not letting this become a professional relationship. We're getting into the personal. And then the next step that happens is the clinician goes, well, I'm above that. I'm not going to commit boundaries. I'm not going to commit barriers. And as a result, they aren't realizing that slowly over time, they're providing that kind of inconsistent rule. And then other things kind of happen, and usually patients kind of end up sleeping together and the boundaries violated. So it's important to recognize when you're skirting that boundary, when you're getting close to that, and you're asking questions. And always you should ask questions that you think are going to help the patient, not that's going to help you. But you should do that anyways. Like, you shouldn't be recruiting patients into your research study if they're your patient for some other reason, unless you're really sure that there's something like about that. So those are all good examples of boundaries. But if you ask every single person the same questions, you can be very reassured that you're probably not doing it because of some other subconscious reason. And yes, it's okay to have kind of friend crushes on your patients and people you just would love to take to dinner, right? Because they're interesting people. Our patients are fascinating. I learn so much from my patients every single day. But just in the same way that they're here to see me, as a clinician, I have to respect the fact that they're also coming and they're my patient, and we have that boundary. So if you are mindful of the fact that your patient is coming to you with a sexual problem as a patient, you're actually very unlikely to cross any boundaries. And if you can use that professional lens that you've already worked on, you know how to talk to patients, then you won't run into any trouble. In terms of how we actually go about doing that, it's important to set the stage. So this is my therapy office, and I'm a big fan of actually compartmentalizing time. So I see people and talk to them for half an hour on end in my one office, but when I'm in my tasky office, I'm tasky. So if somebody tries to bring a sexual problem to me in the middle of my obstetrics clinic, I will provide some information and help them, but in fact, I will defer that to potentially another venue where we can do that, because I know it's going to take too long in that clinic, and I do have a commitment to my pre-existing patients to try to be as on time as possible. So the first thing you do is you set the stage. And that also can mean, even if you don't have the luxury of an office with a couch, is to say that today we're going to talk and the exam can wait. So we have this pressure on ourselves, that whole time thing, that we have to do everything all in one visit. But in fact, maybe it's better to have that emotional conversation and wait for the next step afterwards to have the examination, to separate those out in time so there's no concern about boundary crossing or violation. And that's a really useful strategy in terms of setting that frame. And that way, you know, I'm going to talk about some of these personal things, but I'm not going to introduce the general examination into it as well, so that there's no confounding. And again, sometimes patients who are very emotional about the experiences that they're sharing with you, maybe now is not a good time to go pushing for your own benefit. Most of the problems that I see in the sex therapy office are not urgent. They can wait a few visits. So in fact, any patient who comes to see me with dyspareunia is a talking only visit the first time. They come and see me for exam the second time. They're usually quite refreshed and excited about the exam by the next time because they've already had that grieving moment and they're ready to move on from there. And I find that's a great strategy. The other thing that's really important is to speak patient's language. So this is where you have to get a little comfortable with the fact that your patients, like many of you, have learned about sex from the media. So they don't know all of the fancy terms. You know, they don't know where the vulva ends and the vagina begins and the clitoris is found and the labia minora majora and all that. They don't really understand that stuff. But they have some great catchphrases in terms of using it. And if you use the principle of what's called narrative therapy, in fact, we should be replicating our patient's language as much as possible. Another example of that in my practice when I talk to patients about affairs, I really try to use whatever language they're comfortable using, as opposed to, you know, injecting my own value-laden terms like infidelity or cheating or things like that, because that might not be how the patient sees it, and we shouldn't be trying to plant the seed based on our own lived experiences. Now, there are certain things as a feminist that I really frown upon using vernacular to describe the female genitalia, because we just don't have good enough words that are vulgar for the penis, right? Because it's not an amazing thing either, but I mean, it's there, but the problem is that it's too one-sided. If we did, I'd probably be more comfortable with it, but we don't. So I will gently redirect people towards language that's a little bit more value neutral, and I'm not so picky about kind of them saying it, but I don't always feed it back to them. I think this is another thing where people who maybe are a little uncomfortable about their own values around sex get nervous. And what I want to say to you is the people who are having 50 Shades of Grey sex or hanging from the swings or, you know, the furries and all that, they're not coming to you. They don't have a problem. They don't need to see you. Most of my patients who are struggling struggle with vanilla. So you don't need to be an expert at knowing all the other stuff. You can read it for fun, and if you practice it, excellent, good for you. But if you don't do that, don't worry, because the chains people don't talk to you about it. I mean, having done this for a while now and being very open and permissive, I can't get them to tell me all that stuff. I feel like it's probably not there for those people. The next issue that comes up is that you may not actually know the answer. So the worst part is when somebody asks you a question that you have no idea kind of what you're supposed to do with that. And I see that quite a bit in my practice, actually. There's a lot I don't know. Actually, I know that for sure, as do many of you. And so my approach is what's called the implicit model. And so the best part about what I do in terms of talking to people about sex or personal issues, it can be relationship issues. People will disclose their abuse history to me or disclose their partner's drinking, for instance, and I'll ask them, what do I do next? So the first thing you do is you create an environment where they can talk to you. And you just sit and you don't do anything and you nod and you listen. And they will tell you what they need to do almost all of the time. So the implicit model refers to, it's an acronym, it refers to permission giving, limited information, specific suggestions, and intensive therapy. So if you just give people permission to ask about sexual problems, actually the fact that you've created that environment for them will help them feel comfortable knowing that what they are dealing with is an actual problem. They may actually want to come and see you, and while they're waiting to see you, there's good evidence that people who wait to see sex therapists will actually have improvement in their sexual function before they come and see you. We actually have to do waitlist controls when we use sex therapy trials. And that's because we've just given people permission to legitimize what their problem is. And that is often enough to help for a large number of people. For those that it doesn't help, then you just get some limited information. And from there, all you need to tell people is what's normal. Now for sex, that's a bit tricky. But you know, a good example for that in my practice is what's normal frequency. So if you look at Canadian couples, on average, who are married to cohabitate, they have sex about 5 to 8 times per month. So I see people in my practice who are worried about not being able to maintain once or twice a day. And I see patients in my practice who are happy with once every 6 months, and they're trying to figure out what that kind of, what's that sort of normal for them, right? Another great example is explaining to people that it is normal when you have a child to not feel very sexy and to be uncomfortable and to not be very intimate with your spouse, and that lasts for about a year. And just giving people that information, that knowledge that what they're experiencing is normal will also help reassure them. So you know lots of little tidbits because you've already been studying some of this stuff. I think we as educators need to make sure we talk about sexual issues embedded in other aspects of care. But if you have that information, in fact, that will be helpful to your patients. Specific suggestions, the easiest way to give a specific suggestion is to read back to the patient what they've already told you, especially if they've told you something in a way where you can tell that it's bothering them more than it really bothers you. So those are the examples of, when you explain to me this problem that you're having with dyspareunia, you kind of framed it in the context of when your partner wants to be intimate with you, but you didn't really tell me what happens when you want to have sex with your partner. Can you elaborate on that? So that's a good example of just listening and feeding back to the patient, but listen for those little tidbits. And in fact, in that case, usually what happens is they're telling me they're having sex when they don't want to, and it hurts, and they don't want to have sex. Well, that sounds normal. I don't think I'd want to go to the gym with a broken leg, because it would probably hurt my leg. So not wanting to do something in that context makes a lot of sense to me. Feeding that back to the patient, letting them reflect on that, letting them find strategies to deal with that next time, and actually really help them. And then, when you need help, that's when you send them on for intensive therapy. So really, in the sex therapy group, I probably only need to see about 4 or 5% of most of the referrals I do. Now, if I did that, my success rates for treatment would be a lot lower, so it's good that I see easy patients. But the intensive therapy ones are the ones where you really can tell that this is something that's beyond what you're dealing with. And actually, even for me, in those cases, those are often patients who are in relationships where there's already been a deal breaker. So if somebody wants kids and somebody doesn't, now they have a sexual problem, but the reality is they're dealing with these mismatched life goals. Or there's been repeated infidelity, and in fact somebody's already left the relationship, and they're trying to come back to see me. Or the worst referrals I get are, I've seen 3 relationship therapists and now want to see you. I'm like, oh God, like if you're seeing me, like there's a problem here. So, I think you get hints even from the referral of kind of how this is going to go. And that's where it's absolutely okay. I mean, it's always okay to ask for help, but that's where it's really, really helpful. You never want to give a non-truth to a patient, and also, especially when it comes to sex, you want to be really mindful of the fact that have you learned this information based on some sort of non-evidence-based conjecture as well? So have you been told something in your upbringing that you're feeding back to the patient as fact? I see that actually more in my contraception practice than in sex therapy, but common things I hear, the treatment prevention is having a child. Not particularly helpful information, especially if somebody doesn't want to have a kid, because I don't think any of us in the room would, ever recommend pregnancy as a treatment for any disease, right? But for some reason, people think that's normal, and so on and so forth, right? Or the fact that once you hit 65, like you are non-sexual anymore, corneal frequency of 0 is normal. It might be, but it may actually not be normal for you. And I have patients in my 70s and 80s who have trouble because they can't maintain the high frequency that they have. One couple comes to mind. They were upset because they couldn't have sex twice a day, 6 days a week like they used to. They could only have sex twice a day, 5 days a week, and they wanted to know if that was okay. And I thought, I don't know where you find the time, but by all means, go right ahead. And they thanked me for their time, and they went on their way. And I'm sure 5 days a week they're very happy. And on the 6th day, they rest. So I think that's really great for them. So that's pretty much what I have to say about what I do. And I know people were probably hoping for some really specific meat, but actually it comes down to where you come from and where you start, and really thinking about this from the big picture. If you care about your patients, if you think what you are here to do is to make a mark on the world in terms of improving women's health, and you can recognize the fact that that means everybody, and that means everything, and that means all aspects of the woman, even things that you may not think about for yourselves, which I'd also recommend self-care, very important, then I think that you will be fine. And if you know that you're doing this because you really believe that this is something that's going to help the patient, then I don't think that you're going to make a lot of mistakes. So thank you very much for your time.